Go ahead and get started. My name is Scott Crow, and it is my distinct pleasure to introduce our distinguished visiting lecturer, our friend and colleague, Dr. Joanna Steinglass. Dr. Steinglass comes from Columbia University, where she completed psychiatry residency and then an NIMH postdoc, focusing in the area of eating disorders. Currently, she's associate professor of psychiatry there. She's going to be talking today about anorexia nervosa, which is, as I think she will probably stress, at present a particularly difficult thing to treat, especially in adults, an illness with a particularly high, in fact, the highest mortality and suicide mortality of any psychiatric illness, in a place where we need effective treatments. Her program of research is really a translational research program that aims to understand, I would say, maintenance mechanisms in the area of eating disorders, particularly anorexia. And this has been a long-running interest of hers. In fact, her first paper, actually, which I imagine was written in postdoc, was on the role of habit in anorexia nervosa, which is very central now and was extraordinarily far ahead of its time then. And so I am very much looking forward to her talk, and I hope you'll join me in welcoming her to Minnesota.
Thank you, Scott. It is really tremendously fun for me to be here. The eating disorders group here are some of my favorite colleagues in the field, and so it is very exciting and fun and joyful to be telling you guys about our work, which is a little bit of a weird word to use for the understanding of anorexia nervosa, which is not joyful, but I will hope to interest you guys in thinking about this very difficult problem and hope to shed a little bit of light on it by telling you the kind of the ways that we've been going about it and the stories that we have to tell. I do have to begin by correcting Scott. My first paper was actually on whether or not anorexia nervosa was a delusional disorder. And I am remembering actually the first time I gave that presentation was the first meeting, and Scott was standing in the back. And that is a very clear memory for me. So with that, let me tell you a little bit about, I'm going to start by making sure we're all kind of on the same page about what anorexia nervosa is, and then walk through the ways that we think about it from there. Anorexia nervosa was actually first described a long time ago in the 1600s as the relentless pursuit of thinness accompanied by an intense fear of weight gain, and given its name in the 1800s. And the reason I want to start there is I think it's helpful to remember that this illness has been around for a long time. It is very tempting when we're talking about and thinking about anorexia nervosa to get distracted by ideas about social norms and thin ideals and kind of cultural influences. So I think it is helpful to remember that the illness was described and characterized long before the social media existed, which I also think helps orient us towards why we think about this as a biological illness and why it's important to be focused on this as a more medical and neurobiological area. It has since been described in the DSM-5, just to get us all remembering what anorexia is. It is described by a couple of characteristics. It is a signature feature of the illness is that it is characterized by significantly low weight, accompanied by some form of distortion or overemphasis or fear of weight gain and disturbance in body shape and weight. The DSM helpfully I think this is going to be a laser. Yes, helpfully added some language that that the idea about fear of weight gain can be understood from the patient's behavior, and this is important for people who don't see patients with anorexia nervosa all the time. It is often the case that the patient describes, I know I'm underweight, I know I need to gain weight, and that can be sort of distracting diagnostically. So it's very helpful for the DSM to put out there that that it doesn't have to be experienced consciously as a fear of weight gain, but that you can understand from the patient's behavior and their inability to do what it takes to gain weight that that's what's going on. There are these two types. There are patients who are significantly underweight primarily through restricting their intake, and then there are those who also binge eat and purge, and/or purge. A quick overview of who gets anorexia nervosa. It is really predominantly female to a degree that is kind of fascinating. It is more than 90% female. The prevalence is about 1%. And has not been increasing. So the available data that show us the rate of anorexia nervosa in the population suggest that it's been pretty stable, which again points to something about a neurobiological basis for the illness. The mean age of onset, or the peak time frame, is mid to late adolescence, but actually the mean age in treatment is in their mid-20s. Which is a point I'm going to come back to a little bit later on, but there's a little bit of a gap between when the illness develops and when we're really taking care of patients. It is a very serious illness, as Scott was saying. It has a very high rehospitalization rate, high rates of morbidity and mortality from the illness. Mortality comes in part from the medical sequela and in part from suicide. One of the features of the mortality for anorexia nervosa is that these are young women, so that this is a population who are not otherwise ill, who you would not expect to be dying. And so the standardized mortality ratios are extremely high. This is a kind of, it's 6 times the rate in some populations. There are some where it's as high as 18%, depending on which age range you're looking at. The prognosis with adolescents is better, which again I'm going to come back to later on, but basically if we're taking care of teens, we have a reasonable expectation that they're going to recover from this illness. And when we're taking care of adults, it's much more complicated. Very quick overview of standard treatment. It is very established in the field that the first and critical first step is the renourishment of patients. This can be accomplished several different ways. For adolescents, it can be accomplished through family treatment. For adults, it can be accomplished through a range of structured programs, inpatient, residential, or day programs. But the treatment is really, the most successful treatments use behavioral approaches to help patients, essentially using structure and consistency to override the intense pull of the illness and give people some way that they can make other choices in the service of renourishment. Broadly speaking, medications have not been helpful, with a recent exception of a hint that olanzapine may do better than placebo for outpatients with anorexia nervosa. But in general, medications have not added any advantages over behavioral treatments. That weight restoration piece is the first step of treatment. It is not the whole treatment. There is no reason to think that at the end of renourishment, people are better. The general recommendations are at least a year after that of helping people with maintenance, and with doing the rest of what needs to be done to really recover from the illness. Okay, that's the quick overview. What we have, really focused our thoughts around it at Columbia is this central question of, I've told you it's an illness that is characterized primarily by starvation. It is that the treatment is renourishment, and that medications don't help, that what really helps is getting somebody to eat, which begs the question, why can't these patients eat? So first I'm going to prove to you that they can't eat and kind of get you thinking about how intense and disturbed this issue is. The first data that really quantified that patients with anorexia nervosa are eating less than healthy controls came from Colleen Hadigan, who observed caloric intake. She measured what patients were eating, and indeed, not surprisingly, they were eating fewer calories. This was a very useful study because it indicated that it wasn't just that there was something different going on metabolically, that patients are actually eating less. She also identified that they weren't eating less across the board, but they were specifically limiting their intake from fat. This has again been shown by Robin Sisko, who looked at how patients eat in a laboratory setting, so where the lunch meal was provided as a strawberry yogurt shake in an opaque container. This was a very terrifying situation for patients with anorexia nervosa. And again, they ate very little, but what she added to the story here is that they also ate very little after the full weight restoration treatment. This was a kind of a weird study with a strawberry yogurt shake, so it led to the next question of, well, what if there's more that they could eat? And this is where we started doing these multi-item meals. This is a pretty standard procedure in our clinic, so you're going to hear me talking about this a lot. But this is essentially a lunch buffet. Patients come in, they have what they want for lunch, they ring a bell over here somewhere, a little doorbell when they're done. And there's no tricks to it. It's just an opportunity to have real quantification of actual intake. And Laurel Mayer showed, again, that in that setting, when we're able to really measure what's going on, patients eat very little compared to controls. And again, after weight restoration, they eat very little. And what I want to point out here is that this is 2.5 months later after they've been eating something like 4,000 calories every single day. And their standard lunch for the last couple months has been close to 1,000 calories. But when they come back into this lab setting and they're given, and those behavioral structures are removed, they continue to eat very little compared to controls and compared to their nutritional needs. And again, Laurel showed that this was a specific restriction of calories from fat. The last point I want to make about intake is that we have also shown through a couple of studies that how patients eat actually matters for longer-term course. So in this study, Janet Shebendak kept track of, or had patients keep track of everything they were eating for 4 days, and then we were following them in the course of a year. And this has been replicated, but in this study, she found that how patients eat after weight restoration is associated with whether or not they do well a year later. And particularly, it was limiting diet energy density, which is partly determined by percent of calories from fat, and diet variety score, so that rigidity around eating and limiting fat intake was associated with longer-term outcome. So the take-home point from this part of the talk is that this maladaptive eating pattern is a very central disturbance in anorexia nervosa, with restrictions of intake, restrictions even after weight restoration, disturbances in the pattern of eating, and that all of this matters for longer-term course. So the thing about that is that if eating is the problem, we actually know a lot about eating. So in the medical field and science, we know a tremendous amount about what the biological mechanisms are of eating. We know that there are appetitive drives and that these are mediated by certain neural circuits. We know that there are inhibitory controls that help people to stop eating, and those have different circuits, that there's a gut-brain axis, that there are genetic influences on this whole system. We know so much about eating that we can make diagrams like this with very detailed descriptions of how one hormone leads to another hormone and what all these circuits are. I'm not going to walk you through this diagram. I only want to point out that almost all of the things that we see in this system are as you would expect in anorexia nervosa. So everything that we've looked at in terms of things that signal starvation look the way they're supposed to look and would suggest that the system should be driven towards intake. Except for these two black boxes. So there are these two things that we don't really know enough about. These are the sort of hand waving, there's something else that influences the system, something to do with behavior and sensory input, and this is probably where the entire story is for eating disorders. Because all the rest of these things look basically okay. So it gets us back to our main question, why can't these patients eat? So for that, I'm going to take us to a quick Psych 101 story and a reminder of how, what we know about how behavior is learned. So if we think not so much about all those neuropeptides and how they relate to each other, but think about what's called motivated behavior, things people do on purpose. We know from cognitive neuroscience a little bit about how that behavior is established. We know that there are some situations where behavior is learned and reinforced and rewarded, so that if you have an animal model and you put a rat in a cage and it presses a lever and it gets a pellet of reward, then it learns, oh, if I do this behavior, this outcome happens, I should do that again, I like that. That is considered action outcome or instrumental or goal-directed behavior, and all of that type of behavior is sensitive to the reward value of the outcome. So if the pellet stops coming, the behavior stops happening. And that type of behavior is mediated by the ventral striatum and the orbitofrontal cortex. Then there's a modification of that type of behavior, which is called stimulus response learning or habit learning, where essentially the outcome drops out of the story. So that with repetition of that stimulus response outcome learning, you get a behavior that gets stamped in and becomes insensitive to that outcome. And then it's just stimulus response learning. And at that point, the behavior has shifted to a different neural circuit, which is the dorsal striatum and the dorsolateral prefrontal cortex. So we know all of this from, well established from the animal models and a little bit from translation into human studies as well. In humans, we tend to describe the habit as having certain behavioral characteristics. So we know that habit behavior is not innate, it is learned, it occurs repeatedly and becomes fixed, so that's that sort of outcome-independent piece. It happens with very little conscious effort and is elicited by a variety of cues or stimuli. So with that model of behavior and motivated behavior in mind, we have developed this habit-centered model of anorexia nervosa that has become a way of putting together what I described to you about the disturbances in eating with what we know from cognitive neuroscience about how behavior happens. So the model begins with thinking about the behavior itself. We know that the illness begins commonly through what I'm calling dieting, and by dieting I simply mean that energy intake doesn't match nutritional needs, which means that it can be that somebody decides to go on a diet and decides to lose weight, but it could also be that a kid joins a team and starts running more, and in that setting their energy requirements went up, but they didn't meet them. Or it could be that they got the flu and they stopped eating for something not on purpose at all. So it doesn't have to be that the person intentionally went on a diet, but something occurred and that something was in some way rewarded. And the rewards can be entirely idiosyncratic. So it could be that the individual got some feedback that they had lost weight and they said there was something positive about that. But it could be that they had an internal sense of some kind of feeling of control or something that gave them an internal positive reward, or it could be that they were running better or something like that. Something happens that the behavior is rewarded, and that's that goal-directed piece. So when behavior gets rewarded, it gets repeated. And with repeating, then it can become more entrenched. And with that repetition, we are positing that it becomes this more habitual type of behavior and therefore becomes mediated by a different circuit in the brain over time. The thing about shifting to the dorsal striatum is that that it is potentially less accessible to intervention at that point because it's more habitual. It is more outcome independent, as I was saying before. So that may help us understand why this illness is so hard to treat. So this hypothesis has been very nicely described by Tim Walsh as the persistent maladaptive food restriction in anorexia nervosa can be considered a habit. Another way of saying it that Tim also likes to say is that in the beginning it was dieting for the sake of reward, and in the end it's just dieting where the dieting itself has become the reward and it's just a behavior. And again, I'm using dieting in a particular way in this talk. So if that's the case, now we have a model with some hypotheses that we can set out to test. So the way that we did this is partnering with our cognitive neuroscience department at Columbia and starting to think about the critical feature of anorexia nervosa, I've told you, is that persistent food avoidance and not eating. But the problem we have there is that not eating is the absence of a behavior, and that feels very challenging to study and to measure, and may be part of why it's been so hard for the field to get traction on what's going on there. Because if you think of it as the absence of a behavior, it's not quite clear what to do next. But if you think instead about that persistent selection of low-fat food, then it's not that patients are not eating, it's that they're making particular choices in what they eat. And as soon as we start thinking about choices and decision-making, there is a whole world of information about human behavior that opens up and becomes a lens that can be applied and a set of hypotheses that we can now test. So the way that we have done this is through looking at food choice. So there's a task that was actually originally developed by Todd Hare to look at decision making. He was interested in value-based decision making, and he created this task that allows for individualized assessment, which I'm going to show you in a second. And he was looking at dieting specifically. And we took his task and just changed up the pictures because we wanted to have a set of pictures of food that are representative of what a person would be encountering and what a patient with anorexia nervosa might be making choices about. So there are 76 different items. We worked with our nutritionist to make sure that half the items are high fat and half of them are low fat. That's not part of what the participants are experiencing when they're doing the task, but it just made sure that we had a range of the kinds of choices that they could make. And then the task goes through a couple of blocks. The first two blocks involve the individual ratings of the foods across two different value systems. So they first or second rate the healthiness of the food. So they see each picture and they rate the food according to how healthy or unhealthy it is, where 3 is neutral. And then in counterbalanced order, they rate how tasty they think it is, from good to bad, with 3 in the middle, where 3 is neutral. And the task then selects one item that was rated neutral across both of those value systems for that individual, and that becomes their reference item. And in the final block, which is the block that we're actually interested in for this study, we are looking at choice and how they go about making choices between the reference food on the left, which is always the same, and then the one on the right that changes. And they are instructed that they will receive one of their food choices at the end of the trial, at the end of the experiment. And they do. They receive a snack at the end, a snack-sized portion of each of these foods. So they select their choices. Do they strongly prefer the reference item or the novel food item? And we did that task in the scanner, and then the next day we had the patients come back, the participants come back and do that laboratory meal again. And it's a slightly different meal, but it's basically the same idea. So first I'm going to show you the behavioral data from the task, which basically describes that patients and controls are able to discriminate the low-fat food, which they rated as healthier, from the high-fat food, and that the patients and controls found the low-fat items and the high-fat items equally tasty. So we did this, we divided the items into high-fat and low-fat for the sake of the analyses. That wasn't part of what the decisions that they were making. And then for the choice block, here you're looking at the percentage of time that they chose the high-fat food or the low-fat food over the reference item. And here you can see that the patients with anorexia nervosa were significantly less likely to choose the high-fat foods. This is what I've been telling you from the beginning. This is not earth-shattering information. This is just showing that the task captures the behavior that we wanted it to capture. We've now done this task with a lot of different people and a couple of different experiments that I'm going to walk you through in a minute. But I'm showing you this because this is demonstrating basically the ecological validity of the task and showing that the percentage of time that they choose the high-fat choices, this is the patients in orange and the controls in blue, is significantly associated with how much they actually eat in the meal. So this tells us that what we're capturing when we're looking at what's going on when they're making choices in the scanner is relevant for what they're actually doing when they're making choices in this critical decision for patients with anorexia nervosa. So here's what we found. So in the first study, we had about 20 patients and 20 controls. And what we did here was a parametric analysis of what parts of the brain are active while they're making choices. So this tells us which brain regions are associated with choice for patients and for controls. And you can see here that, as you would expect, the ventromedial prefrontal cortex, where they're doing sort of decision making and assessment of the value of the food, is active for everybody. So this is sort of a validity check of the task. No difference between patients and controls. You'll also remember that our specific hypothesis was that it was going to be that for the patients, it's the dorsal striatum that's active when they're making choices. And indeed, when we did this direct comparison, we see that for patients with anorexia nervosa and not for healthy controls, there is activity in the dorsal striatum that's guiding choices. We also showed that it wasn't in the ventral striatum. It was pretty specifically in the dorsal striatum. We look to see in a PPI analysis to assess what's going on in the circuits, just to see what other regions are active in association with the dorsal striatum. And if we start with the seed in the dorsal striatum, we do see that there's a region in the dorsolateral prefrontal cortex that is active as well, that is correlated with it, suggesting that there is a dorsal frontal striatal circuit. This graph here is really just to illustrate that the strength of connectivity is related to food intake in the lab, again, just suggesting that there's a relationship between the circuit and actual food intake. Okay, so this is where, for those of you who have heard every part of this talk so far 20,000 times before, now you can stop taking notes. Hopefully you have time to finish all your emails, and now I can take you into some new territory. We just completed the second version of this study where we looked at not just what happens in acutely ill patients, but also what happens after weight restoration. And in that study, we also looked across the spectrum. So we had two sets of questions. One is, does this change when they get renourished? And the other is, where in the course of illness or restriction does this come to pass? So is it that this is inherent in the illness? Is this a feature of starvation? Is this a feature of dieting? So I'm actually not prepared to show you those data yet, because we aren't very far along in analyzing the results, but that will be coming down the pike. What I can show you a little bit of is what happens with weight restoration. So as you would expect, this is the behavior. So again, the patients with anorexia nervosa don't eat, and they don't eat after inpatient treatment. And they also continue to restrict their calories from fat. Now, our hypothesis in this study was actually that with treatment, we optimistically thought we would see that patients are able to, with that very intensive behaviorally based treatment, day in, day out, they're learning to make different kinds of choices on the inpatient unit, that maybe in the setting of the task, where all they have to do is pick a snack for that day, that they would make different choices. And sadly, that is not the case. At the end of treatment, they continue to make very restrictive choices in the task. Our first pass, this is again highlighting new, so that those of you know that you haven't seen this before. These aren't quite ready for prime time, but this is just the first pass of looking at what happens in the brain after weight restoration. Mostly what I can show you here is that we have a decent sample size and that we have reason to think that the pattern is likely to persist, but we don't have, these need to be cleaned up considerably before we'll know whether or how well we've replicated the finding. But certainly it looks like after weight restoration, it's still there. So that's a little bit depressing and leaves us thinking about how persistent this particular problem is and how entrenched. I mean, we got into this because we thought it was entrenched and we were worried about what that is. But I have to say, this was a little grim. So then we turn our hopes to adolescent anorexia nervosa. And the idea here is that if you go back to the model, what we've said about all this is that this is learned behavior, and it has to develop. It doesn't, they're not necessarily, or we're hypothesizing that they're not born with this, that they develop anorexia nervosa. So that would suggest that the behavior or the circuits mediating the behavior are shifting. So our hypothesis really is that there's a progression of what guides food choice in anorexia nervosa. So that early on in these youngsters, we should be able to see more of the goal-directed, more of the reward system relevant for making food choices. And then that later, with persistent illness, the dorsal striatum and the habit system would come online. So what we're able to do with the teens, we're doing a study of 14 to 18-year-olds, a large study we're anticipating, and we're going to be able to basically take advantage of what I told you in the beginning, that the prognosis is better for adolescents. So what we'll be able to do is characterize brain circuits when they first come in, and then follow them for 2 years. And our expectation is that about half the sample are likely to do well, and about half the sample will continue to struggle. And we will be able to compare which brain circuits were engaged in food choice at the baseline assessment and how that relates to outcome 2 years later. We are a year in. So in the first year, we have 33 adolescents. I can show you the behavioral data. I can't show you any imaging data. We don't have that analyzed at all yet. Another shooter? That's terrible. It's exciting. That's a fire drill. Want me to keep talking, or you can't hear me over that? So the earlier one was to prepare me for this one? Is that the... Nobody moved. I do not. Nor will I get away from that noise. You can't hear me if I keep talking, right? You wouldn't be able to hear me if I tried to just keep talking. Well, if we do actually have to wait, we're a little behind.
The verdict is it's just a fire drill, so we don't need to do anything. So we'll cut through this slide, which basically is just showing you that the kids do the same thing as the adults, which, though sort of depressing, it does mean that we'll be able to measure what we want to measure. Okay, so all of what I've described to you takes what I would call a top-down approach that really starts with the behavior and aims to understand what drives it. What we can also do is look at the systems themselves and examine, well, how are these systems functioning in these patients? Is there something that we can learn from a bottom-up approach if we probe the circuits a little bit more directly? We are pretty partial to the importance of the top-down approach and the importance of really measuring active food-related decision-making and kind of centering on the illness phenomena. But obviously, these two approaches should meet in the middle so that there's a lot to learn from probing the circuits as well. And sometimes you sort of have to go back and forth to figure out what you're trying to figure out. So that gets us to reward systems. I'm going to try to
hurry through this a little bit, which is kind of dangerous because it's a little complicated. But basically, there's a lot of people interested in reward systems in eating disorders and in anorexia nervosa in particular. And there is reason to think that there is something disturbed in these systems. There are papers looking at the kind of general functional connectivity of the reward circuit. And when I'm talking about the reward circuit now, I'm talking really about the ventral striatal or the mesolimbic circuit that we were talking about as kind of the goal-directed system from the beginning. And Annie, who may still be here, did one of these papers looking at resting state functional connectivity, and now a few groups have shown different kinds of impairment, not always in the same direction, but that there's something disturbed for the patients with anorexia nervosa. Guido Frank's group in Denver has looked at prediction error. So what happens to the reward system when an expected reward is omitted or when a reward is received unexpectedly? And they have shown that for adolescents and adults, there's a difference in the responding in the ventral striatum. Again, just suggesting that there's something that's different in the functioning of the system, never mind what's going on with food choice. We've also shown that there are deficits in learning, in reinforcement learning, so that patients with anorexia nervosa are essentially slower to learn from reward. There's more to this whole story. You know, people have come at this from a number of different directions: reward processing, reward learning, reward responsiveness, and all of it suggests that there seems to be something different in the system. So one of the ways that we have been probing this goal-directed versus habit and sort of ventral versus dorsal, or these questions about what is driving behavior in anorexia in general and how do these systems function, is by using the so-called two-stage task. And this is the version of the task that we use. I'm going to try to explain it. Hopefully it's familiar for some of you, because it takes a while to understand. But basically, in this task, you start out on one planet, and you pick a spaceship, and the spaceship takes you to another planet, and then you pick a guy, and if you pick the right guy, you get some space gold. And the idea here is, so that's what the individual sees. We could stare at this. This one takes a while, so staring at this one is actually helpful. The idea here is that I'm going to try to just keep going. Bear with me. Okay, so the idea here is that sometimes that if you choose well, this is actually this is like a dual task for me, because this is the hardest slide to talk through, and now I have to do it with a distractor. Okay, so what? Yeah, we'll see what I say. Okay, so the idea is that if you have what's called a model-based representation of how you receive rewards, then you figure out over time, I think of it as like having a picture of the whole chessboard, and you figure out that you should do the thing that's most likely to get you to the planet where you're most likely to get the best money. If you have, however, what's called the model-free approach, or the arguably more habitual approach, you're simply responsive to the reward. So if you got the reward, you're going to do what you did last time, and you're not really going to see the whole thing there. So this is when you're playing for space gold. Now, there are what we know about individuals, all individuals, is that people use a little bit of the model-based approach and a little bit of the model-free approach when they're solving this kind of task, and that there's variability in how much healthy people use each of those. The question for anorexia nervosa is whether they're doing it differently. Now, I have said that I think these patients are more habitual, so you might think that they would use more of that habit-based approach. But on the other hand, you could look at patients with anorexia nervosa and say, well, these guys are relentlessly pursuing a goal. So isn't that, by definition, the model-based approach? So it's a real question. What are they doing? As I understand, you guys have wondered as well, do they do that differently for money than they do for food? So for our version of the food-based task, we tried to keep as much of the design the same, but they're choosing these choices where the outcome has to do with food. So they're playing for tokens, just like here they're playing for space gold, and what the tokens give them is more or less choice about what they're going to have on the snack after the task. So it's a currency, but a currency that's going to be used for food. And this just kind of shows you that what you would expect is that people stick with this is what we were describing about the differences between model-free and model-based in how people go about solving the task. So in our study, we had 53 controls and 41 patients, and what we found is that they don't differ in the extent to which they use their model-free approach, but the patients are less model-based, which if your hypothesis was, but this is a relentless pursuit of thinness, shouldn't they be more model-based? It counters that. But if your hypothesis was about model-free, well then this doesn't really tell us very much. The thing about this picture is that it also looks very similar to most other psychopathology. So what we then did was compared the food versus money versions, and what we saw there was that it really doesn't make any difference, that they are no more model-based when it comes to food than they are for money, and also before and after treatment didn't make any difference. Okay, so take-home point number 2 is that this eating behavior thing really is a problem, seems to be guided by these dorsal striatal neural circuits, but leaves us with a bunch of ongoing questions. And the ones that we're looking at now are trying to think about biomarkers that could tell us about the course of illness. Is there one circuit or another that's more relevant for longer-term course? And can we use these computational approaches to parse out decision-making better? So that we aren't stuck with a picture that just looks like every other psychopathology. Can we use these algorithms to better understand maybe there are elements of decision making that these computational models will help us with. Okay, for the very last part of this talk, I want to shift gears to the treatment development side. So one of the things that we were thinking about in the beginning of this model is, in addition to the neuroscience side, what does it mean about the behavior? If this is a habit, what would we do? What would we do differently? What would that mean? And here I always like to start and sort of pause on the Bernstein Bears. When we started talking to patients about this question of their behaviors and what does it mean that they do this over and over again and that they get stuck, could we think of these as habits? There was a patient that I was talking with who gave me this wonderful metaphor, and I started using the metaphor over and over again, and then I told her that I liked the metaphor, and then she said, well, it wasn't my metaphor, it was Grandma Bernstein's or Mama Bernstein's metaphor, and she sent me this book. And part of what I take from this is that there is nothing new under the sun, and that all that we are doing is essentially captured by the wisdom of Grandma Bernstein. But if we look in the right places, maybe we can find something. So what Mama Bernstein said, so this is little sister Bernstein is biting her nails, and she can't stop. And they keep trying all different kinds of things to help her stop. And Mama said, it's sort of like this path. I've wheeled this barrow over it so many times that it's worn a deep rut right down the middle, and it keeps getting deeper every time I use it. Why, it's so deep now that I can't get out of it without a little help. So we tried to devise some ways to help. And when I say we, I'm talking about a treatment development intervention that we did in collaboration with Carol Peterson here, and Steve Wunderlich and some others, where we just kind of put our heads together and tried to think about a closer look at behavior and at routines. And we found our way to the Self-Report Habit Index, which it comes from the social science literature, behavioral science literature, as a way of capturing the strength of a habit. And this scale essentially measures how outcome independent it is, how frequent it is, how automatic, things like that, and has been useful in other areas of behavioral research. So we took that as a way of measuring the maladaptive eating patterns in anorexia nervosa. We looked at 4 different domains of maladaptive eating, and we measured habit strength, at the beginning of an intervention, at the end of an intervention. And what we did was a very small pilot randomized trial on the inpatient unit. So patients were getting their regular treatment along the way, and half of them got this habit-changing therapy, and half of them got supportive therapy. And the habit-changing therapy really emphasized this idea that behavior has become outcome independent. So that as we're sitting there telling patients, here's why you need to change, here's how this is ruining your life, here's what you need to do differently, that is useless information if the behavior is not dependent on the outcome and is only dependent on the cue. So in this treatment, we focused in really closely on what all the cues were for the behavior and helped patients develop new routines and become more goal-directed in that setting and figure out ways to suppress their old routines that are stimulated by those cues. This was 11 people in each arm, and yet we saw, and it was 12 sessions, we saw a significant improvement for the patients who got the, we called it REACH, which is this changing habit intervention. This is the measure of habit strength. Not only that, so this, some of our local cynics always look at this and say, well, you called the treatment changing habits and the patients told you that they changed their habits, they just like you, which may be true, but that's why we looked at other measures as well. And in this little treatment, we see that this is a measure of eating disorder severity. So we see this overall difference in eating disorder severity where the patients who got this habit-changing intervention improved more. And then here's the part that we're particularly fond of, even though I keep making the same typo on the slide, which is looking in the laboratory meal at how they actually eat. And I showed you in the beginning how incredibly hard it is to change eating behavior, and that when we give them months of treatment and they don't eat any differently in the lab. And yet in this study, we have this tiny study, nearly significant difference in improvement in intake in the lab when our intervention focuses in this very intensive way on behavior. So this, in some ways, is a proof of concept study that suggests that there's something in this model and there's something important to pay attention to here about how the behavior is stuck. So my final take-home points are that by focusing in on mechanism, we can do much better in our treatment interventions. In this case, for anorexia nervosa, it's really this granular focus on the eating behavior itself that may be our path forward. And for us, we're particularly interested in this maladaptive food restriction as being a core salient feature. Now, since it's the day after Election Day, I was thinking to myself, what would my campaign slogan be for all of this? And it turns out there's a reason I'm not creating campaign slogans, but I do think it's nice to leave on a slightly optimistic note about a very difficult illness, and to think that as we move forward in learning more about mechanisms, there is hope that we will be able to change these behaviors. And that's it. I will just point out that if anybody around here doesn't want to stay in the Midwest, we also have a T32 over in New York. So, thank you.
Hi. This relates to treatment of anorexia, and I'd be interested in your opinion of a specific approach to treatment that also, as you pointed out, focuses on the habitual nature of the disorder. Specifically, the approach used by Södersten and his group in Stockholm, and their focus is on trying to restore the eating behavior itself using kind of implicit learning techniques.
Yeah. So there are different ways that treatments have creatively focused on behavior, and my assessment, is that when you really make that behavior central to what your treatment intervention is, you can get some traction. There are so far a few different ways that seem to do that. We've done it with exposure therapy, and we've done it with this focused behavior, this reach treatment. But there are other ways. So I guess for that treatment, I don't know that like all these others, it has not emerged as a clear winner or anything like that, but it certainly seems like the preponderance of evidence is for very laser focus on behavior as a way to help people get unstuck.
Thank you for that wonderful talk. I have several questions, but I'm thinking about the results with the two-stage task, where there was less, basically not a difference in habit type responding,
Right.
but a difference in reward type responding. And I'm trying to, can you think me through that conceptually?
Yeah.
Is that a sort of a sample size? Just couldn't.
Well, so the thing we probably can tell from it is it's consistent with the other data that reinforcement learning is slowed or impaired or in some way deficient. So I link it with our reinforcement learning findings, so that the model-basedness may be about learning. The model-free part is tricky because part of the interpretation is that the task itself isn't as sensitive to model-free behavior as it wants itself to be. So the collaborator for that is Nathaniel Daw, whose task it is, and that's sort of where we landed, is that it just doesn't budge across psychiatric populations, across individuals, across different kinds of manipulations. It is much easier to see changes in the model-based part than the model-free part. So it kind of lands us with, maybe that didn't quite answer our question. Now, we didn't do imaging, so we don't know if there are differences in what's going on in the brain while people are doing the task. And sometimes there are advantages to tasks where the behavior is similar, because then you aren't puzzling over your interpretation of the brain findings, meaning that if you have similar behavior and you see a difference in the brain, that is potentially telling you something different than just, well, they were doing different behavior, so of course there were different brain correlates.
Yeah, thank you for a wonderful talk. I'm really fascinated by this idea that there's a transfer from ventral medial or prefrontal areas to dorsal striatum, and from value-based choice to habitual choice. But one of the things I'm trying to understand is that if that's really strictly true, let's simplify that's the whole story. Why isn't the solution just to have eating in a context that's cue-free? So why can't these patients eat food that has absolutely no cues about the fat content? I mean, so you started off, and I'm very naive about this whole subject, but with the slide showing that the strawberry milkshake in the nondescript container is terrifying for these patients. And so but that seems like a separate message from this is habitual, there's a cue about fat content, and they have, a goal-directed choice towards choosing low-fat content foods.
So I think that the task that would address your question would actually be more like sham feeding. So there is always a cue. There is external cue and there's internal cue. And of course it's never that simple. So these are also, I think the piece of the model that is less well accounted, the piece of the story that is less well accounted for in that particular model is the rest of affective influence, the rest of I think where fear learning fits in is not fully addressed in this model. We have come at that from in separate studies, but haven't yet linked the two. One potential, I think it was on one of the slides, one potential way to think about linking them is actually, well, what if it's not even an approach habit? What if it's an avoidance habit? Then that's a whole different set of structures that may need to get accounted for as well. So part of the answer is there's never a cue-free environment, and part of the answer is there's never a simple answer.
Thank you for a really wonderful talk and for your poise with these really unfortunate and incredibly irritating interruptions.
I'd already forgotten.
And I think you actually just answered my question, which was simply a variant, I think, of what Alex was going to ask, which is essentially that these changes in model-based learning systems with respect to habit learning systems are seen across psychiatric disorders. So what's going on uniquely here in eating disorders? And I think you answered it in part, which is that likely there are these contributors, again, from failure modes in these other systems as well that are uniquely associated with food cues, body image, et cetera.
I would add to it hints of things that I'm curious about that may be driving the system. I don't know the answers, but in adolescence are there's so much going on with brain development, and one of the things that we know about is the shift from model-free to model-based predominance occurs across adolescence. So the kids are all model-free and adults are more model-based, and adolescents, it's just starting to come online. So if the dieting is happening in adolescence, if that's when the shift in behavior occurs and that's what's going on with brain development, does that influence towards habit systems for this particular behavior? Because that's the behavior that they did, and so that's where they went with it, and that's how the pathology developed. So there's a little bit so they had to do something to get the whole thing started, but there may be other influences on the adolescent brain that are particularly relevant.
And again, may be relevant in other psychiatric disorders as well.
Absolutely.
So why females?
I have no idea, and that is there are others who have a better idea than I do about why females, but I think it's at my current I think I led you to that question because I want to know why females, and my hope is that actually we'll start studying men more because maybe we can actually figure out something about why females by trying to figure out what happens with these. If you think of that as sort of the rare variant and the way that the rare variant could help us learn more about the predominant phenotype. But that's my way of getting out of answering the question.
Are there animal models of anorexia, specifically those that are induced by behavioral manipulation? Because it just seems to me implausible that any kind of reward initially would extend in time and allow the animal to forego food and die.
Right.
So
exactly.
If you can't induce it in animals, how is it a fit model for humans?
So there are a couple of animal models. We could use more. We could use better ones. The features of behavior that have been modeled, the most common one is the activity-based anorexia model, where rodents can be induced to exercise, and a fraction of them develop the phenotype of preferring not to eat, and they will exercise themselves. But as you were pointing out, they can't sustain that, they die. So it's very hard to study it, and it's also really not a full picture of what the illness is.
They do die. I mean, you train them, and then they exercise too much and don't eat.
They do. Okay. Yes, and that's not all of them, right? So there's some that will develop that phenotype. But it doesn't, what that ultimately captures is the activity side of anorexia, which is a common feature, but isn't a defining feature, so it still doesn't, it's a little bit unsatisfying as a model. Many models have focused on binge eating, and those end up ultimately being good models for studying obesity, but not great for studying eating disorders. And then there's a newer model Lori Zeltzer has developed, which I'm fascinated by, and I'm hoping it pans out. But she basically has a genetic factor and a social stressor of isolation of the animals that essentially leads to these dieting mice, so that a fraction of them, or rats, I never remember, but a fraction of them develop this voluntary aphasia, and they do it episodically. So they don't die because they do it episodically, but they do it so that those animals become a really interesting model for voluntary refusal of food. Apparently, it's very labor intensive or cumbersome or expensive to find those animals, and and to capture the behavior at exactly the moment that they're going to choose to engage in it. So she has found that to be a really challenging, really provocative model, but ultimately hard to use for the kinds of questions that we're trying to use. So she's doing the next level of that model to figure out how to kind of expand the phenotype.
Hi, I have a kind of a basic question, or just a more global. Can you relate this habitual model to some of the other ways of thinking and changes in cognition with anorexia nervosa?
Meaning,
like when you're treating patients, you see them as perseverative and concrete, and like your first patient, first paper, possibly delusional, almost thought disordered.
Right.
And
some of it is exacerbated by malnutrition. I wouldn't say alone, but I think that a lot of what we see in the neurocognitive phenotype of anorexia is so affected by starvation and doesn't improve quickly. So part of it is that the brain doesn't bounce back that fast, so that you have people whose cognitive rigidity is presumably related to undernourishment and kind of conservation of resources in some way. And then we expect that will improve by renourishing them, but it turns out that the brain just needs longer than the rest of the physiological changes that go with starvation, and so it doesn't improve right away. So then we have all these people who are still struggling with those kinds of thought patterns, and that I think is a difficult setup for then they return to old behavior patterns. So I guess I would think of that as an influence of starvation, and probably related to, there must be something about the hit of starvation to the brain that affects this whole system. I have not seen much that really clearly answers that question of how does cognitive rigidity relate to actual eating behavior. We don't have much information about that.
Is cognitive rigidity seen in other forms of severe weight loss, such as, might be due to a medical illness?
Right. It is seen in the Ansel Keys study of the Minnesota semi-starvation study, where they showed all of the neuropsychological effects of being undernourished in these otherwise healthy men, and they showed that probably mostly showed the attention and memory patterns. We wouldn't have had the same measures then, but showed some of that in that setting. The comparison with other medically ill populations has not really been shown, usually because people decide that the medical complexity is too hard to figure out what's actually going on. So there's not as much data.
Thank you for your talk. I was thinking about the circuitry, and it's, again, very fascinating, this kind of ventral dorsal switch, and about typical comorbidities of OCD in the context of eating disorders, and more specifically, whether or not that switch is really coinciding with the ego-dystonic versus ego-syntonic behavior, that initially you're conflicted about weight and body image and so forth, and that's the ventral contribution to that circuitry. And And then ultimately, when you start moving to this habitual thing, whether or not from a clinical standpoint, you're also seeing a egosyntonic kind of a behavior, and that's how, and that whether that affective component is really responsible of that, or at least moderating a little bit the switch from the ventral to the dorsal.
So the dilemma I have is that all of the patients in my studies are coming voluntarily seeking treatment. So they are, clearly they have the ambivalence that's part of the illness. It's not that they have some different illness but they are, in many ways, they've chosen renourishment and treatment and all of that. So they're trying, they would like to get out of this mess and they can't.
Is there some kind of a prodromal group that you could study before a group that may or may not develop the symptoms? And is that the population you're looking at, the adolescents that haven't become habitual? Do you consider them to be the prodromal group?
So I would I guess I would say it's a step towards the prodromal. I don't think we've figured out yet how to study the prodromal because it would be all of adolescence potentially. But the idea is that if we can capture those, I didn't show the characteristics, but our sample has even our 14 to 18-year-olds have a nice range of duration of illness, so that we expect to be able to see at least very early on in the illness and if that looks any different. I think it would be great if we had a clearer understanding of what a prodromal phase looks like, and as opposed to a general, normal dieting phase. And if we could figure out who those people are, that would really be helpful.
I have a comment on the cognitive effects of starvation that you, particularly in reference to the Ansel Keys study that you already referred to. I mean, as you know, he studied a group of men, and he did a very detailed psychological profiling on all these men while they were eating their normal diet. And he got a range of behaviors in different dimensions for depression, anxiety, etc. And then he studied them again 6 months after having them on a 1,000 calorie a day diet. And what he found, the changes, the profile really shifted, and you get all the changes that you see in adolescents and young women with anorexia, with anxiety, depression, delusions, etc.
Binge eating.
Yeah.
Oh, I just had a couple, maybe this has already been done, but in terms of the prodrome, maybe studying like young dancers or models. Wouldn't that be like a high risk, at least an enriched sample, because they have a high rate of developing symptoms because they are actively, or wrestlers, if you want to look at boys.
Right.
Because they do develop eating disorders.
Yeah.
And then for the animal models, I've just been wondering if people have thought of maybe they've tried this and it didn't work, but trying to replicate the Minnesota study and because my understanding of that study is they basically undernourished them, and then the subjects, the human subjects, then developed lifelong abnormal eating. Maybe they didn't have anorexia, but I thought they had persistent abnormal eating. Is that not true?
No, I don't know if somebody else has a better. Scott's shaking his head. No, my understanding was that they returned to normal, but maybe it takes 3 years.
Okay, I think one time I saw a play about it, and it was how they went on to have okay, I'll have to look into that. Maybe that was fiction, the play that I saw. But it was about the Minnesota study, so okay. Yeah.
Oh, sorry, I didn't answer the animal model question.
Oh, yeah.
Have they just starved? I think it would be great. No, I don't think that. What I would love for somebody to do that we haven't yet convinced anybody to do is some of these kinds of, these tasks come from animal literature. And so what if we just looked at what happens with model-based, model-free learning in starved animals? And we haven't convinced anyone to do that yet.
Your comment about changing learning processes with development. Made me kind of think, do we have any idea or do you have a guess as to what's the impact of persistent malnutrition on, is that, it sort of seems like it should be bad for learning, but I don't know.
Right.
What do you think?
I
Does
think
that have an impact?
I assume that it has a big impact and that is a piece of what we see, but I don't have evidence of that. I think it's why we all keep trying to figure out duration of illness, and whether the duration, and can we get early on and prove to ourselves that there's something about the extent of time of being undernourished that impacts the longer term course.
Keep going here as long as we're... this question I was thinking about, is there anything, because I was also interested in this idea that let's focus on the presence of a behavior as opposed to the absence of a behavior, which is difficult to study. Is there anything, once these people are weight restored, that becomes normal or is preserved? So the volume of food they eat, or the mass, or the number of bites they take, or the motions of hand to, do we know anything about that actually is normalized, if you will? Yeah.
So the population I have to answer that question in is recently weight restored. And so I'm beginning to think that is not the most relevant stage of illness for some of the questions that we have. I think what you're asking is, well, what if we looked at a fully illness recovered population? What kinds of eating behavior changes what would be no longer problematic and what would still be problematic? I don't have an answer for that. My assumption is that it's pretty, within the range of variability of healthy controls once they're fully recovered. Again, within a certain range of healthy controls, I don't know. Does anybody else have a thought about that?
I think, I think there's a wide range. I think that there are people who eat in a relatively healthy way with considerable difficulty and a high level of motivation. And I think there are people that eat in the way that a lot of us do without giving it a lot of thought. And I wonder if we were talking last night about some people who seem to be doing great, and then all of a sudden, after sometimes a very long period of time, they're drastically not. I wonder if maybe that, why is that? I don't know.
I don't know.
Walt Kay's group at UCSD, his position is to really allow for sort of phenotypic preference, if you will. So he allows weight restoration of similar foods that, when you're an outpatient, you can kind of have the same thing for lunch every day, pushes less variety than a lot of other programs do, because this assumption that you're going to see a preference toward the same food each day. So, and I think there's still some long-term outcomes showing that in weight recovery and long-term progression, you still see a preference for lower fat diets, is my understanding.
I would certainly believe that. I don't know whether it's within the variability of healthy controls at that point, or if it, because. And actually, what may be informative is when we look at our healthy dieting sample. So for the large study I showed you before and after, the analyses remaining to be done are going to look at a group of people who do not have an eating disorder but eat restrictively such that they have lost some weight, and then people who have an eating disorder but are not underweight. So they have clinically significant restrictive eating as sort of an atypical AN kind of a cohort, but they aren't CDC level starved, and that'll give us a range.
Thanks for a great talk, Joanna. So I wonder if you have any thoughts about if anything about behavioral inpatient weight restoration tells us, and the response to that tells us anything about habit processes. Specifically, you would think that in some ways it's intervening upon habit, not explicitly stated, but in the context of eating, where you have all the cues, you're changing responses over and over again.
Right.
So I guess my question is, would the fact that people can change their behavior under those conditions suggest that, suggest that it is a habit process, or would the fact that it doesn't stick say something about like there might be something else going on, or maybe it's not long enough? Do you have thoughts about that?
I mean, I don't know if it tells us much about habit and habit mechanisms. It tells us how persistent the illness is and how entrenched the behaviors are. We addressed this question a lot when we were working on exposure therapy, and people really wondered, but isn't the inpatient unit exposure therapy, what if that doesn't work, why would a more focused exposure therapy work? And I think it gets back to this behavior question in general. My experience with the overall structure of a behaviorally based program is very effective at helping with weight restoration, but it really doesn't dive into the individual's behaviors. And I think some of these more laser sharp behavioral treatments that really, the level of detail we went into with people about the cues for their behavior would definitely be missed on an inpatient unit.
All right, please join me in once more thanking Joanna.
You have been disconnected from the meeting.